it from your side. Perfect.
No, I still don't have the ability. Host disabled attendees screen sharing.
If you need me to share it from my screen, I would do that.
But if you can make me host, it will be possible.
Yeah, sure. That's Engineer Haitham, if you will do that.
Okay, thank you.
Have it? Okay, perfect.
Yes. Okay, so my talk will be brief, and I'll be mainly talking about the evolution of bariatric surgery through history. So the first bypass was actually done in the 1950s, early 1950s, but it was an ileocolic or regional ileal bypass, which means they put part of the ileum, a small bowel, and they attached it directly to the colon. So it bypasses part of the small bowel. And the same thing, they take a small part of the beginning of the small bowel and they attach it to a more distal portion of the small bowel. That's the second one, which is called jejunal-ileal bypass. It was invented in the beginning mainly to treat hyperlipidemia, since the medications weren't actually out in the market yet. The problem with it, it was mainly malabsorptive procedure, and a lot of patients presented with severe malnutrition and even liver failure. With the evolution in the 70s, they, let's say, invented the first gastric bypass, which was later on modified to what we know nowadays as the Roux-en-Y gastric bypass in the 77. Then in 1980, they discovered or invented again the vertical banded gastroplasty, which is the picture on the upper picture. It means they put like a ring on top of the stomach to make it a small pouch. It's a restrictive type of procedure, which means the patient can't eat as much as before. Then in the same era, the Scopinaro in Italy invented the biliopancreatic diversion, bypassing most of the small bowel and the bile and pancreatic fluid, which means the food goes directly, let's say, from the mouth to a small portion of the stomach and then jumps to the large bowel with just a small portion where it's mixed with the biliary and pancreatic fluid. It's also a malabsorptive procedure, so you lose calories that way. They added a small modification to it in the early 90s with a duodenal switch. It's a bit complex, but it also has the same principle of bypassing the biliary and pancreatic fluid. So we have less absorption and we lose calories, then hence we lose weight. The biliopancreatic diversion with the duodenal switch, which is on the bottom right, is still performed till these days, but over the years is constant, about 5% it's still performed. In the 1990s, they came up with the other surge of the Roux-en-Y gastric bypass. Then, all what I said before was actually done in laparotomy, which means open surgery. They used to open the abdomen. The first laparoscopic gastric bypass, as we know it today, was started in the 1994. With it, they started the first operation of laparoscopic adjustable gastric banding, al-halaqa, okay? The picture in black and white, okay? It started in the USA, not in 1994. All this was in Europe, actually. In the States, until it was FDA approved, they started, I think, in 2000 or 2001. After that, they came up with the concept of the sleeve gastrectomy. And since the early 2000s until recently, the sleeve is starting to go up in numbers in comparison to the other surgeries. Why? Because it's a simple operation. If you go by the principles, it's a simple operation and it does not require a lot of dexterity, maybe doesn't require that much of skills in laparoscopic surgery. So this is just a simple graph to show the decline in that time of gastric bypass and the uprise of the sleeve gastrectomy. As we see in the bottom, the purple line shows the duodenal switch, which is, as I said, is still stable. Not a lot of numbers, but people still perform it. So just like a small summary, a mechanism of the three major types of bariatric procedures. So the first one is the gastric banding, which is somehow no one does it unless really in certain conditions. So it's a restrictive, between brackets, it's here behavioral, which means the patient is not capable of eating large amounts of food. The one in the middle is the sleeve. It's also restrictive. So patient is not able to eat large amount of food, but also it has a physiological malabsorptive and other enzymatic processes that help with the weight loss. The third one on the left, it's the bypass between the Roux-en-Y and the gastric bypass and the mini gastric bypass. It's both also restrictive, malabsorptive, and it has its metabolic effect, which helps in all the metabolic disorders in addition to weight loss. Okay, I just want to thank Dr. Mohammed Ghanem, his bariatric surgeon and colleague and friend, who helped with these slides. And I'd like to present to you Professor Dr. Norbert Runkel. He's the chairman of the largest bariatric unit in Germany, with more than 1,000 cases of bariatric surgery per year. It's an clinicum in Offenbach, Germany. He's an expert in the field of bariatric surgery with more than 10,000 operations under his belt. He's one of the founding members of the German bariatric surgery. His specialty is mini gastric bypass in addition to revision surgeries, which means patient has all maybe one of the procedures I talked about, sleeve gastrectomy, Roux-en-Y bypass, or other procedures with complications or with problems of weight gain. He is specialized in turning from one bariatric procedure to another. In addition to that, he's a visiting professor to the Saudi German Hospital Group, and hopefully soon he'll be visiting us also in Jeddah. Professor, I give you the floor.
Thank you very much for this kind introduction, Dr. Amali Bari. Let me first start with saying many thanks to Dr. Ayed for the kind invitation. I'm very honored to be with you. And I'm also proud to be affiliated with the Saudi German Hospital Group and be given the chance and the opportunity to contribute to the excellence of surgical care that they are providing to the patients inside the kingdom and outside. Let me look for my presentation now. Today's focus is on metabolic surgery and the role of mini gastric bypass, which is another operation that I'm going to explain to you in a very short moment. Who would have thought it? This is a landmark publication by the great Porys, published in the Annals of Surgery in 1995. And this paper introduced metabolic surgery to the bariatric surgeons. An operation proves to be the most effective therapy for adult onset diabetes mellitus. This is a graph from one of his first patients. This patient started off with a blood sugar level of nearly 500 and at a daily insulin dose of 80. The day after the operation, blood sugar dropped dramatically, and within a couple of weeks, the blood sugar levels normalized. Within 1 day after surgery, the insulin dose, the insulin requirement dropped to 10, and within a week after surgery, the patient was off insulin. This was a wonder. And the astonishment by Porys is expressed in his title, Who Would Have Thought It? He analyzed his patients with diabetes mellitus type 2 and realized the remission rate of diabetes of about 80%. And the remission rate was even higher, approaching 100% in patients with an impaired glucose tolerance test. These figures, ladies and gentlemen, have been reproduced since in every country, in every center all over the world. These are data from our center, 10 years old, and they show the downgrading of diabetes after the operation. And this occurs very early, within the first weeks, up to 3 months after the operation. The downgrading of diabetes precedes the weight loss. The weight loss is shown here, and the nadir is after 12 to 14 months. What are the parameters influencing the results of downgrading? We analyzed the variables, and it is the severity of diabetes, shown by the DiMaria score, the duration of the disease, and the excessive weight loss. So in practical terms, if a patient has a diabetes history of less than 5 to 10 years, he has a very good chance to get off the medication thereafter. If he's on insulin for 1 or 2 years only, he also has a very good chance to have a full remission of the disease rapidly after surgery, as long as he is losing weight by surgery. Does the original weight have an influence on diabetes remission? This question has been examined in this meta-analysis. These are all the studies, including patients with a BMI above 35, the hazard ratio is 0.7. Comparing to the patients with a BMI of less than 35, the hazard ratio is the same. And this shows very nicely that the success of the operation regarding diabetes remission is just the same in the heavyweight patients as it is in the lower weight obese patients. We can offer the operation to any patient independent from their original weight. This is being emphasized by the following study of a longitudinal database analysis from the States. It's 10 years old. They have examined the subgroup of patients who were less obese with the BMI below 35. It was 1.2% of those 66,800 patients, of which 28% were diabetics. That is 235 patients. That is the change of BMI after the operation. At that time, remember, more than 10 years ago, it was the gastric band on the one side and the Roux-en-Y gastric bypass. They were the standard operations at that time. And you see some, but not a lot of effect by the gastric band on the weight, losing BMI 33 to 30. So not really effective, is it? But the Roux-en-Y did induce a drop of BMI from 35 to less than 35. So basically the Roux-en-Y cured the patient from their obesity. Let's look at the diabetes. Now, this includes now the remission of diabetes, respectively the downgrading of diabetes, red in the group with gastric band, and blue in the group of patients with a Roux-en-Y. And you see that the downgrading parallels the weight loss curve. So if you want to induce remission, you have to bring down the weight. The weight is in the center of all the focus that we surgeons do. Whatever you do, you have to bring down the weight and you have to choose the operation accordingly. That is the message of this curve. The very first meta-analysis in bariatric surgery is from the great Buchwald in JAMA 2004. They published a remission rate of diabetes early after the operation of 80% and more, which has been reproduced all over the world since, but also a high rate of remission of hyperlipidemia and hypertension, which we summarize as the metabolic syndrome. I'm personally very much impressed by the success on the liver. On the left side, you see non-alcoholic fatty liver disease. The remission rate is nearly 90% in the meta-analysis. And on the right side, you see a case of fibrosis, perhaps a bit of cirrhosis too. And yet, in this very advanced liver disease, the remission rate is 30%. Who would have thought it, ladies and gentlemen? And I'm so impressed, I want to show you a histology of one patient, having been published. The upper row gives you the index of fibrosis in the liver. You see the fatty liver degeneration and fibrosis of the liver. And within 5 years, the liver has an absolutely normal appearance. And the lower row represents the inflammation, the infiltration with inflammatory cells, and yet within 5 years after the operation, the liver looks perfectly healthy. This is a great success of bariatric surgery. The data have been derived from the Roux-en-Y bypass, and Dr. Malebari has explained to you the Roux-en-Y gastric bypass. Let me re-emphasize: it has a small pouch, gastric pouch, and the pouch is reconnected to the stomach, to the small bowel. The small bowel has this Roux-en-Y configuration. We call this the elementary limb. It usually is 150 centimeters long, and the biliopancreatic limb measures about 50 to 70 centimeters. This is the standard proximal Roux-en-Y bypass. It's the gold standard nowadays in bariatric surgery. But over the last 10 years, the sleeve gastrectomy has become the champion. The majority of patients worldwide are undergoing this operation. It's a fairly simple operation compared to the Roux-en-Y. The stomach is being reduced and it's transformed into a tubular structure, and there's no manipulation on the small bowel. So the sleeve gastrectomy is a purely restrictive operation, but the Roux-en-Y gastric bypass is also mainly restrictive, and it has a minor malabsorptive component. Let us compare those two operations that are so popular nowadays. I refer to the Stampede trial, or the Stampede trial by Shower. It's a 3-arm study comparing the Roux-en-Y against the sleeve gastrectomy against the control group. And the upper graph is the change of body mass index after the operation, which is basically not much changed in the control group, but there's a significant drop in both surgical groups. But the Roux-en-Y group fares better than the sleeve group. They have a better weight loss after surgery. The lower graph depicts the level of glycinated hemoglobin, which represents diabetes mellitus. There is some improvement with non-surgical medical treatment, but the hemoglobin level come back to the original level within 2 years in the control group. Yet both surgical groups have a tremendous impact and tremendous improvement of their glycated hemoglobin levels. The Roux-en-Y group is significantly better than the sleeve. If you look at the graphs, ladies and gentlemen, you do see something on the long run. There is some slight weight regain in both groups, yet the sleeve is doing not as good as the bypass. And there's also some increase in the glycated hemoglobin levels with time. If we do look at the subgroup of patients with complete remission after the operation, with complete remission of diabetes mellitus, you see that the numbers decline over time. In the Roux-en-Y gastric bypass group, they drop from 42% to 29% after 5 years, and in the sleeve gastrectomy group, from 37 to 23%. That means that about a third of our patients who have complete remission early after surgery, the diabetes will relapse with time. a third of patients who have complete remission of diabetes soon after surgery will relapse on the long run. This is an important message. Who are these patients who relapse? We do not know, ladies and gentlemen. We don't have any prognostic parameters. This study looks at the weight curve, and 3 groups were examined. Those patients who never remitted with their diabetes, those patients with durable remission, and those patients who initially remitted and later relapsed. And you see that the patients with durable remission have a higher weight regain than those who remitted and relapsed. So there is not a prognostic parameter in weight regain. But the patients who never remitted, they had the initially they had the same curves and also the same weight loss after surgery, but they did regain weight on the long run. And perhaps this represents a different phenotype of obesity. So again, weight regain does not definitely correlate, does not predict diabetes relapse. We have to look at these patients very carefully on the long run. Now, you may wonder whether it's worthwhile operating on patients when diabetes may relapse. This is the relapse-free survival curve of those patients who relapsed after initial remission. The 50%, the median relapse-free time is 8 years. So in other words, even if patients relapse who had initial remission of diabetes, we have given them 8 years freedom of their diabetes, an 8-year interruption of disease, an 8-year delay of progression of the disease, an 8-year improved survival rate. So it's worthwhile offering the operation to those to diabetic patients. But still, we've seen the problem of relapse, and the question is there another operation that can do better than the Roux-en-Y or the sleeve? Biliopancreatic diversion with duodenal switch is another classical operation, and Dr. Malibari has shown you that it is still being performed in very low numbers all over the world. Because it's a complicated operation. We have the construction of the sleeve. The duodenum is being transected behind the pylorus. It is then connected to the small bowel. This is a hand-sewn anastomosis. The bowel has this Roux-en-Y configuration with a short common channel of 1 to 2 meters and an elementary length of 150 centimeters. Complicated operation, yes, but very, very successful. This is the excessive weight loss curve in the patients, which approaches 90%. And furthermore, ladies and gentlemen, it's very stable. The weight curve is stable. The blue line here represents the drop of weight after the operation, 1 year, 2 year, up to 5 years. And you see the blue line is constant. Once the patient has lost weight after biliopancreatic diversion, usually they remain stable. They do not see weight regain. This is a 3-armed randomized study by the Mingron group comparing the biliopancreatic diversion versus the Roux-en-Y versus the control. And again, you see that the Roux-en-Y does have this slight weight increase with time. Now, you may personally wonder, looking at this picture, that the Roux-en-Y is doing better with weight loss than the biliopancreatic diversion, but this is not true. This is not the excessive weight loss, ladies and gentlemen. This is a weight in kilograms, and the patients with the biliopancreatic diversion started off with a much higher weight. So please remember, the biliopancreatic diversion is more successful in weight loss and keeping this weight loss over time. Now let's look at the diabetes. And interestingly, again, here in this group who was so successful, there's some relapse of diabetes in about 30% of the patients with initial remission. Now, the biliopancreatic diversion starts off at a very high, at a comparably high level of 95%. So at the very end, we still have a high 63% remission rate with biliopancreatic diversion. And this is a great success of surgery. So you may wonder why we don't perform biliopancreatic diversion in every patient, in every metabolically ill patient. The reason being, it is a very complicated operation. It has a high perioperative mortality of 2 to 3% perhaps, which is significantly higher than our standard operations. And it also has a high postoperative morbidity of 20% and more. There's a new operation. Well, it's not that new, but a new operation that is increasing in numbers all over the world. It's called the mini gastric bypass. It's a one anastomosis gastric bypass. It is comparably simple. A long gastric pouch is being constructed, and it is connected to the small bowel in an end-to-side manner, leaving a biliopancreatic lymph of a length of 150 to 200 centimeters, and it can be varied in the appropriate circumstances. The excessive weight loss, the excessive weight loss from the studies is impressive, and it's nearly as good as the biliopancreatic diversion. It is definitely better than the classic Roux-en-Y. The operation has been invented by Dr. Robert Rutledge, and he's traveling the world convincing everybody of his technique. I have prepared a video. Let's see whether it's working. It's a four-day-old video from a patient from this week. You see it's that we're looking up the angle of His. You see in the background the spleen, on the top the fatty liver. We open the window there. Now we turn to the stomach. This is the nervus latagiae. The stomach is on the right side. We're going beyond the angulation, and we are disconnecting the minor omentum from the lesser curvature of the stomach. The aim is to enter the lesser sac. You see the pancreas, the fatty pancreas in the back. So we are behind the stomach. We are now able to introduce this stapler. It's a 45 purple cartridge, and it's being fired in a 90-degree perpendicular angle to the smaller curvature, 45 millimeters. You cannot transect the stomach completely. It's just impossible here. The next shot is again a 45 purple, and it's directed towards the greater curvature in order to have a broad base. Now we turn to the 60 millimeter cartridges, and we're going back to in direction of the smaller curvature. Calibrating tube is being introduced by the anesthetist, and you see this resembles the creation of a sleeve, but it's not as tight as a sleeve. It is not as close to the small curvature, and there's less bleeding. The top is being prepared from the back. The top and the front has been prepared as the first step when we started the operation. So we're heading towards the left cruise, again, 60 millimeters. And you may think the stapling is finished with this one. You're always surprised. There's always 1 centimeter. You can see the tip of the stapler is directed toward the right side of the spleen. You do not want to hurt the spleen at this moment. Okay. You think you're ready? No, there's still one centimeter. You're always using 1 stapler more. I think that's one of the laws in bariatric surgery. You always use one more. So you make sure the stomach is completely dissected. There's no bridge, because that will be dangerous. Leave it. So we're now looking at the base of this tubular stomach, the pouch. This base is being opened for the later introduction of the stapler. Oh, I'm sorry. Okay, I'm sorry. I wanted to advance the film to be more rapid. Okay, a hole is being made just in front of the staple line, just a bit right to the crossing of the first and the second stapler. That's where we enter our linear stapler. Okay, small hole for the introduction of the stapler later. Now we turn infracollically, we push up the omentum, we identify the small bowel and the transligament, we count the bowel, we measure the small bowel. In this case, we choose 200 centimeters. There's an opening made into the small bowel antimesenterically. Again, a small hole for the introduction of the stapler. It's a 45 purple linear stapler into the small bowel and into the stomach. And now this is very crucial. You place the stapler a bit towards the lesser curvature. So you do not have parallel staple lines, and you make sure that there's a good blood supply in the corner of the stomach. So there's no parallel staple lines. Fire, it's a large anastomosis. It's not a small one. It's much wider. It's a non-obstructive anastomosis compared to the Roux-en-Y anastomosis. You check for bleeding, and there's just one hole that has to be closed by hand. We start with a corner stitch on the right side. Then we turn to the left side. Oh, I'm sorry. That's the problem with technique. If you want to make it fast, it just doesn't like it. Let me see whether I can find it here. Yeah, it's a running suture. I'm back. Yeah, it's a running suture. We are traditional. We are using a simple vicryl zero. It's a running suture. It looks nice. That's it. We inspect the anastomosis for leaks and bleedings. We check for good blood supply of this corner of the stomach. Then we fill up the stomach with methylene blue to test for any leakage. And that's it. It's a straightforward anastomosis. It takes about less than an hour. And you can do it in the very obese patients too. The super obese patients too. Well, where's my talk? Okay. I'm back again.
Maybe you need to share the screen back, please. Maybe it was.
Have I? You see my screen? Do you see my screen?
No, actually not. Maybe you need to share it again.
All right.
Please.
Okay. Can you see my slides now?
Yes.
I'm sorry. So
Uh,
you're back again?
yes, you are back.
All right. Now this is a picture from Rutledge's paper, and he emphasizes that you should be you should be away from the angulation of his, and you should create this base. He calls it the cobra head, to really make sure that you have a nice blood supply. This is the cobra head technique. This is a key point of this operation. You have this opening through the transverse stapler line of the stomach, and you have this ventral opening that is being sutured and closed. The operation is straightforward, has a very low postoperative complication rate of less than 1 to 2%, a very low leak rate. And also the long-term complication rate, ladies and gentlemen, is about 10%, roughly the same that we know from Roux-en-Y gastric bypass. It is the ulcers, up to 10%, the severe biliary reflux, about 2 to 5% in my view. You have minor deficiencies in iron and vitamin D, as you have in other operations too, but the one that we fear most is excessive weight loss, malnutrition, and hypoalbuminemia. The rate is 1 to 2% only. So it's a very successful operation with a low long-term complication rate. This is a nice graph of the time-wise distribution of late complications following surgery, and you see that there's no clustering, a time clustering of complications. Complications can occur anytime after the operation, and this really emphasizes that we have to take care of our patients after the operation. We have to look for them, we have to screen them, we have to see them regularly in our outpatient office. A few points I want to stress. Internal hernias are extremely rare in this operation, despite the fact that we do not close the mesenteric defects. And you remember that internal hernias are a true problem and a real problem in the Roux-en-Y gastric patients. There's also little leaks. The leak rate is less than compared to the sleeve gastrectomy. And there's also few cases with anastomotic strictures because the anastomosis is done widely, much wider than in the Roux-en-Y gastric bypass patients. So again, no clustering of complications. Take care of your patients after the operation. The interesting thing is that we've learned so much positive things from the mini gastric bypass that we bring back elements from the mini gastric bypass to our Roux-en-Y patients. This is a randomized study from Holland. They compare standard Roux-en-Y gastric bypass with an elementary limb length of 100 centimeters and a biliopancreatic limb length, biliopancreatic limb. Despite the fact that the excluded length of the small bowel is just the same in those two groups, the latter group does better. It has a better weight regain early after the operation and up to 4 years after the operation. And we have learned that it is the biliopancreatic limb length that determines the success of the operation. Another topic is the length of the pouch. We are usually constructing the standard Roux-en-Y pouch with 5 centimeters. In the mini gastric bypass, the pouch is 15 centimeters long. This Dutch group compared the standard length 5 centimeters versus a 10 centimeters long pouch. And the early weight loss is the same in both groups, but on the long run, the weight loss is maintained. There's some weight regain in the short pouches that we've seen earlier. So these are 2 elements that I'm doing now in my Roux-en-Y patients. I have a long pouch, long BPD length in patients that I construct a Roux-en-Y. And it seems that there's no higher rate of ulcerations in the long pouch and less dumping also. This is a slide from India. It looks for the number of patients with weight regain of more than 25% of their initial weight loss from the nadir. Weight regain is significant in sleeve gastrectomy patients. Up to 35% of patients experience that, 50% after the Roux-en-Y, and only 3%. So the MGB is similarly to the biliopancreatic diversion. It maintains the weight loss. There are a few patients that really rise in their weight after the operation. Now, these good results in weight regain, severe albumin deficiency, 2.9% after sleeve, similarly after the Roux-en-Y gastric bypass, but it's doubled in the mini-gastric bypass patient groups, which is low overall, but it's still significant. And again, please take care of your patients after the operation. Remember, these are data from a country where most patients are vegetarians. Do we change the life of our diabetic patients other than a better glucose control? Yes, we can. We can avoid tertiary complications. Here's the rate of fatal cardiovascular events from the Swedish obesity group. And you see a decline, a significant decline of those of the number of cardiovascular events in the group of. So I want to mention that we have an impact on cancer neogenesis. This is a new study by Schauer from the registry. And we have a tremendous impact in ladies on cancers that are associated with metabolism and chronic inflammation. And finally, the topic of prevention. Diabetes develops in patients, these patients, 8% after 2 years.
Professor Norbert, I think there's some interruption of the voice.
25% after 10 years, but of the surgery on diabetes. And I would like to conclude and thank you for your kindness of listening to me and forgiving me for the technical errors. Bariatric surgery is metabolic surgery. If you treat a patient, the patient's obesity, if you reduce his weight, you will improve his metabolism. And if you want to tackle diabetes, you have to bring down his weight. Thank you very much for listening to me, and I'm happy to answer questions.
Thank you, Professor Norbert, for your nice presentation and your nice video. Here I am. I have a lot of questions from our participants. We have, fortunately, today more than 500 participants today. We're starting with the guideline. Are there a guideline for the metabolic surgery right now or not? In other way around, when to do the metabolic surgery?
We have guidelines on bariatric surgery, and we have now included metabolic surgery into the concept of bariatric surgery. And there are guidelines regarding diabetes. There are no guidelines regarding hyperlipidemia or hypertension, but the international guidelines from the diabetes societies, they have included metabolic surgery as into the armamentarium of disease. That means that if the patient diabetes is difficult to control, or if the diabetic patient has a weight of more than 40, BMI 40, he should be advised in surgery. So basically every obese diabetic should have the chance to be consulted by a bariatric surgeon, and he should discuss with his surgeon about the impact of surgery and the chances of remission of diabetes.
Okay. Other question regarding what about the recovery time after the mini gastric bypass?
It is basically the same as in all other operations. The patient is on water right after the operation. He is up out of the bed. He can drink water freely from the day 1 onwards. He's out of the hospital in 2 to 3 days. It's a laparoscopic operation with little pain, and as a surgeon, you would not see a difference in their recovery as compared to the sleeve gastrectomy patients. It's very rare.
And the usual question for the obese patient: when to re-eat again?
When to, yeah, that is in fact, Dr. Dalavi, this is in fact an important question to the patient. We personally keep them on liquid diet for 4 weeks, and thereafter they can restart the food. But the patients are very happy not to eat, actually, because it's the first time in their life that they are successfully controlling their hunger. They are very happy being on liquid diet and see that the weight is dropping rapidly.
Okay, I'm having here one of our audience, Professor Rajab Al-Zahrani, our ENT consultant in Saudi German Medical. He's asking about the relation between the snoring, obstructive sleep apnea, and obesity surgery or metabolic surgery.
That is a very good question indeed. I have not spoken about obstructive apnea, sleep apnea. There is a rapid improvement within 2 to 3 months. Patients can get rid of the mask, and their breathing is better. It starts very early in the postoperative course. Within 2 to 3 months, they are usually off their mask. The success rate is more than 90%.
Even in the patient below BMI of 30?
No, I'm talking about sleep apnea. Is that correct? That's what you're asking?
Yes, yes.
Oh, the patients are usually heavier. Sleep apnea is usually...
Yes, they are usually heavier. Mm.
Our patients with sleep apnea, they are usually with BMI of 40 or 50 and more, and still they recover from their sleep apnea within weeks.
The importance of sleep apnea is also, if the patient is on the CPAP, on the machine, he should get it with him to the hospital and inform the anesthetist. So it's not a major disease. It's resolved by losing weight, but we just need to know it beforehand. So if
yes, I agree with you. It is very important after the operation. They have to bring in their machine for the days after the operation. But usually within weeks they take off the machine. They can sleep without it.
Exactly. Yeah.
Also, I'm having here one question from the surgeon: what to do in case of reflux after surgery?
He's right. Reflux has become a major problem in bariatric surgery. Reflux and weight regain are the major indications for revisional surgery. Now, there's Roux-en-Y, there's hardly any reflux after Roux-en-Y, and we consider today that Roux-en-Y is the best anti-reflux operation anyway. And if you have a patient who's suffering from reflux and he's obese, probably reflux is better than fundoplication. The bypass is better than fundoplication. We are waiting studies for that. Now, if the patient develops reflux de novo after his operation, it is usually sleeve gastrectomy, because there's a high intragastric pressure and there's a high frequency of intrathoracic migration of the gastric sleeve. We start off with giving PPI, but the failure rate is very high, and most patients with a hiatal hernia after sleeve gastrectomy require an operation.
Okay, thank you. Technical 5, also one question here about recovery time, regime.
The frequency.
Are there a contraindication? Are there a contraindication in mini gastric bypass or not?
Mini gastric bypass. The
contraindication, yes.
The contraindication to mini gastric bypass, in my view, is significant reflux prior to the operation and a pre-existing hiatal hernia. because they will develop bile reflux after the operation in the esophagus, and that is very troublesome. You can't cure biliary reflux. You can't give medication for that, and they all need hiatal hernia repair and conversion into Roux-en-Y. So we do endoscopy in every patient to exclude those with a hiatal hernia.
What do you think of pediatric or adolescent age group and performing bariatric surgery on them?
Pardon me?
What do you think about pediatric and adolescent age group, like 12 years old, 14 years old, and bariatric surgery?
Oh, you have a point there that I have a personal opinion, but I do not have experience. And this is due to the fact that our healthcare system basically does not allow us to operate on children. And the pediatricians in our country are very, very conservative, and they are very far away from surgery. I would not hesitate to operate on my own child if she or he was obese, because they have their life in front of them. And I would like to have my children a good start in life, and you have no good start in life if you're obese. But it is very difficult to operate on children in Germany. So my experience is very little. It's basically young adults, 15, 16, 17 years old, but you have a high restriction and a high level of ethical problems with these patients. So very often I usually wait until they turn 18 and then I operate on them. It's much easier. I don't know, is it better in your country? Do you have a chance to operate on obese children?
No, it's very rare. And as you know, a lot of papers are coming out from the United States. But in our country, it's rare. It happens, but it's still rare.
Yeah, it's quite rare all over Europe too. Yes. But I think we are going to face an increasing number in the future, because the young adults and the children are getting more and more obese. We have to have an answer in bariatric surgery to this population group too.
Yes, exactly.
I have also here one more question. Are there documented gastric or esophageal cancer risk in a long run or not?
Yeah, this is the classical question. As long as you do not have reflux, the rate of esophageal cancer is low. So there's basically no recorded Barrett cancer in the patients with Roux-en-Y. In fact, Roux-en-Y cures Barrett's metaplasia. There have been case reports of adenocarcinoma of the gastroesophageal junction after sleeve gastrectomy. And the studies show now that we have a rate of about 15% of Barrett esophagus after 10 years. So this is significant, and we are a bit worried actually that sleeve gastrectomy promotes reflux, which then promotes esophageal cancer. But that just shows us, let us have a surveillance of our patients after the operation with regular endoscopy every 2 or 3 years, perhaps. The question whether MGB promotes reflux cancer is interesting, because there is biliary reflux too, and the combination of bile and acid really promotes gastroesophageal cancer. But we have looked up the case. We have published the first case report of an adenocarcinoma after MGB. The numbers are very rare, and there's only a theoretical but not a practical risk of cancer of the esophagus and the stomach. So my answer is no, there's no increased cancer of risk after Roux-en-Y gastric bypass. There's most likely no increased risk of cancer after MGB. And there's probably some increased risk of esophageal cancer after sleeve in those patients with severe chronic reflux disease.
Any other questions, Dr. Ammar or Dr. Nadim? I think we shared a good
That's
number of
all I
questions
have.
and interesting presentation from Dr. Norbert. If we would like to conclude from your side, Professor Norbert, Dr. Nadim, Dr. Ammar, any conclusion or take-home message?
Take-home message from my side is that bariatric surgery is a very successful surgery. We are offering an operation to our dear colleagues, diabetologists, pediatric surgeons, gynecologists. We have a powerful weapon against obesity. Please use it for the sake of your patients. And especially they want to prevent secondary complications like diabetes, which is running through a family. If you operate a young person from this family without diabetes, you definitely prevent diabetes on the long run. And once they have developed complications, metabolic complications, or even tertiary complications, we still have a great impact on the quality of life on these patients. Please take us as your partners, and we decide together. We decide on our patients' health.
Thank you, Dr. Nadim.
I can't add anything else. Prof. Norbert said it. Together, it's a teamwork. It's not only the surgeon and the patient. It also includes the endocrinologist, the anesthetist, the nutritionist. It's a whole team. It's not only one surgeon by himself.
Thank you, Dr. Ammar.
I really enjoyed your presentation, Professor.
Thank you, Dr. Ammar.
Lose weight.
Lose weight. Perfect. Okay, that's the message. And I want to really conclude here and thank Professor Norbert really for the exciting presentation, and Dr. Nadim and Dr. Ammar for their support and contribution and stimulating questions. And I want to have this opportunity to thank 500 participants from more than 16 countries. We have participants from US, from Egypt, from Philippines, from South Africa, South Sudan, from Yemen. And especially I want to thank Saudi German Hospital Group in Cairo, Professor Magdi Basyouni, our bariatric surgeon there, Saudi German Hospital Sana'a, Dubai, Ajman, Sharjah. We can see many Saudi German Hospital Group members are participating in our event, in addition to our hospitals here in Saudi Arabia, in Jeddah, Riyadh, Dammam, Hail, Asir, and Medina. I hope that it was a fruitful lecture for all of you. We will send you a feedback a questionnaire on the email and WhatsApp. Please take some time to fill it so you will able to help us to improve these webinars and make it more interesting and more fruitful. I want to thank all our professors and colleagues, and looking forward to see you in our future webinar. Thank you very much.
Thank you, Dr. Ait.
Thank you.
Thank you.
Thank you.